Our nursing care consists of ongoing observation, assessment, cleansing, debridement, and dressing reapplication. And as ordered or necessary, we'll prepare the patient for non-surgical debridement, our antimicrobial therapy, graft care, donor site care. We'll talk about the donor site in a minute. You think the donor site's painful? Yes. So debridement usually is done 1 to 2 times a day. There's a couple different types. Mechanical debridement, like hydrotherapy in the shower or tub with a mild detergent, or enzymatic debridement, autolysis, which is disintegration of a tissue by their own cellular enzymes. They don't use this very often with large burns because of risk of infection. And then topical enzyme agents that are applied directly to the burn once a day with a dressing change. And these enzymes digest necrotic tissues. Dressings, standard wound dressings, sometimes they do multiple layers of gauze over a topical agent, and that would be the open or the closed. That'd be the closed. And the number of layers depends on the depth of the injury, how much drainage, mobility, frequency of dressing changes, typically changed every 8 to 12 hours. And then there are biosynthetic dressings and synthetic dressings. The biologic dressings, there are several different kinds here. And the homograft is from a cadaver. It's expensive, $750 to $1,500 a square foot. Has to be thawed in a warm bath before they use it. Heterograft is from another species like a pig skin. Amniotic membrane, larger in size, lower in cost. Cultured skin, grown from the patient's own skin. And then artificial skin made from beef collagen or shark cartilage. And then we go to wound coverings, skin grafts. And that has to be placed on a clean, granulated bed or on a necrotic area that has just had tissue removed. So that's where you most definitely have to have all that eschar removed. Now that picture of that extremity that I showed you just a second ago, that was a picture of a mesh graft. And that healing time is slower because the skin has to fill in around those open areas and attach to the granulation bed. Obviously, not all grafts are successful, and you've got risk for infection. And here we talk about donor sites being painful, and there will be scarring a lot of times from donor sites. And here's a picture of your meshed autograft being applied and then healed. Doesn't that look good? So we've gone from the emergent to the acute phase, and now we're to the rehabilitation phase. And it begins anywhere from 2 weeks to 8 months after the burn injury, when the wounds have healed and they're beginning to engage in some level of self-care. Our goals for the rehab phase are to resume a functional role in society and rehabilitate from any functional or cosmetic post-burn surgeries that they've needed. And sometimes they're just multiple surgeries that they're faced with over the next months and even years. Our emphasis during the rehab phase is psychosocial adjustment and prevention of scars and contractures. So I put in parentheses, you don't leave joints in a flex position, because what do you think that could cause? Contractures. And you're hoping that they'll be able to resume some type of level of pre-burn activity, depending upon the severity of their burns. This phase can last years or even a lifetime if they have permanent limitations. And typically people have a disturbed body image in this phase. Sometimes they become depressed. Some therapeutic behaviors would be for the patient to be willing to touch the affected body part, adjust to the changes in their body function, use strategies to enhance their appearance and function, and begin to work through the grieving process. And you got to try to get these guys plugged into systems of support. Common emotions in the burn patients, and I know you all have just gone through your psych, most of you all, your psych rotation, but common emotions are fear, anxiety, anger, guilt, depression. Do you think the 21-year-old guy Krista was talking about went through some of this stuff? Guilt, depression, happy birthday, you know? Anger. So let's just take a step back now and look back. Our four structures in the integumentary system. Epidermis. Well, how thick is that? Then you go to the dermis. Still thin, but about 1 to 4 millimeters thick. These are your two areas or structures that have nerve endings. So your first degree burn is going to be involved, and your second degree burn are going to involve these two. The subcutaneous tissue then, and then your appendages, skin appendages. Your classification of your burn injuries. Tell me, first degree is called superficial. Second degree, there are two types of second degree burns. Superficial partial thickness, superficial deep thickness. What are your two painful burns? And then your third degree and fourth are deep thickness burns. What's a first degree burn look like, usually? What type of burns require pain medicine a lot of times? Second degree burn, you're going to have blisters usually, some redness. And we classify burns according to three things: your depth, your extent of the burn, and your location. Know your rule of nines. Your phases of burn management: emergent, which is your resuscitative, about the first 72 hours. Your acute phase, which involves most of your wound healing. And then your rehabilitation phase, which is your restorative phase. Questions? Yes?
When they do the fasciotomy, I'm assuming they put some kind of covering over those.
Yeah. We got to decrease bacteria invasion. What I need for you to understand is, and this is where I don't want you guys to catch in the gray area, the difference between a fasciotomy and an eschar-otomy. Okay, eschar, I'm removing the tissues, right? Fascia, I'm opening it up so that I can allow for some sort of collateral circulation in that tissue. So think about it this way. You haven't had musculoskeletal yet, but when you do, we'll talk about compartment syndrome. Each individual muscle striae has a compartment to it, and the inside of that muscle is contained, right? So if there's bleeding inside that muscle, what's going to happen? It's going to become edematous. It's going to swell. So what happens is it decreases the blood flow into the rest of the muscle striae, which causes me to be at risk for losing that limb. Okay? It's characterized by a lot of pain. Essentially, that's what's happening here in these burn patients. They have a circumferential, issue, any kind of problem that decreases my muscle's ability to move, my skin's ability to move, decreases blood flow into that area. It's the same thing as wrapping an ACE bandage around it really, really, really tight. Okay, going to decrease the flow. Okay, so what essentially we're doing is cutting that ACE bandage in a fasciotomy. Okay. A sclerotomy, I'm just removing the dead tissue. Okay? That can be cosmetic. It can be because we have an infection. It can be different things, okay? Going to remove the blackened area. Yeah.
In the fascioti, do they actually remove pieces of like sections, or is that just cut
Cut.
after it's expanded?
They cut. So take me back to that. There we go. Okay. So you see right through here? This is literally, they just go in and cut. And so what happens from that pressure is the expansion. So that's where you're thinking maybe they removed these sections. Absolutely not. This is a cut. This is one cut straight. And then the pressure is what pops that open. Okay. So am I going to cover that? Oh yes, I'm going to cover that, because if not, they're going to die of infection anyway. So I really have only just decreased the chances, saved a couple of days. Am I going to cover that? I'm not going to put anything on it that is going to require a whole lot of moving. It's going to obviously be sterile. What kind of room is this patient going to be in?
Isolation.
Total isolation. Grandma wants to sing flowers. Sorry, Grandma, nothing's coming in. No visitors unless we absolutely have to. But in this situation, this person, I'm looking here just in this patient, they're in the OR, obviously. We have circumferential neck burn. I can only imagine we have facial involvement. We have bilateral arm involvement. We have circumferential chest involvement. What is my possibility of actually making it? Zero, honestly. So what I might do at that point is start to involve the family, because we need to probably focus on the family at that point to help them get through this process, okay? Because if this person doesn't die from the burns initially, they're probably going to die from infection. Yeah.
Later on, like say it was just on his chest, later on, would they go back and take the rest of the estimate off?
Yeah. That's just
don't do it right now because he's probably not gonna make it.
So, we're just going to expose them even further. The only reason we're doing this in the short term is to be able to keep them alive so they can breathe. Okay. Yeah.
So as he shrinks back down to normal size, that's when it kind of close together and then they can go in and suture it.
They would never suture that. That is something that is going to heal from the inside out if it does. And when we're looking at this patient, and I'm realist, is this going to heal? No. So I'm buying some time for that family and trying to do the best I can to try to keep them alive in the short term. Anyway, what?
Is the fasciotomy painful?
Well,
I mean, even if it's on the arm like that, is
yeah. Actually, it in most cases, so for example, if I had a compartment syndrome, and a lot of people who are athletic, who are runners, sometimes will get idiopathic compartment syndrome. You don't know why they have a swelling inside that muscle compartment, they just get it. When you go in, obviously you're going to have pain from the nerve, right, when you enter it, but this patient's not going to have pain from that, right? What are they going to experience, do you think? Relief, right? Relief of that pressure, relief of that pain that is coming from that muscle strain.
Can you imagine the amount of pressure that was under that if it opened that much just with a single incision right there?
Yeah, this is one single incision up, to the side, to the top, and across.
And how deep is that incision?
How deep? Yeah, but, maybe an inch and a half, something like that. And literally, it's cleaning as best as you can in that burn area, taking that scalpel. He started here, and he's moved back to here. He's pulled through here, he's gone in there, in the neck, on the other side, on the arm, and across.
If he's burned the same way on his back, is he gonna have the same?
I would not necessarily flip him over, because now I've allowed for enough movement in the chest.
Right.
And you guys kind of get where we're going with this. It's a hard recognition once you figure out, and most of us go into nursing to do what?
Save lives.
Save lives. The reality of it is you can't save them all. There are going to be people, and as I stand in front of you, the Reaper will claim me one day. You know what I'm saying? So at this point, for this patient, I'm going to focus on the family, because they're going to need some help to get through this. Okay.
Eileen, did you?
When you have patients like this that have extensive burns, are you like putting on sterile gloves to try and handle them, or just anything? Like at this point, it doesn't. Like if someone had a lot of burns, do I want to put on sterile gloves first before I address them, or do I just put on regular gloves? Or
Okay, well, it just depends, okay? Obviously, once they get admitted, yes, everything's gonna go sterile. In the field, is it gonna make too much of a difference? No. And I'm gonna show you a video on Monday. We'll talk about the Valley bombings. We'll talk about terrorism and how those bombings can, people, multiple casualty incidents. So you have a lot of people coming in with burns. What do? And the people in Australia, some of the nurses in that burn unit will talk about how they have different levels of clean. You're coming from the outside, you're completely contaminated. Someone puts you in this room, and you're going to be a little less contaminated. Then we move you over here, and you're going to be a little less contaminated. So then when we get you admitted, you're going to be in isolation. So the goal is, I can't immediately go into the scene. These medics cannot go immediately into the scene and be sterile, So but when they come into the ER, I'm going to do the best I can not to introduce any further foreign bacteria to this burn, knowing that, I'm just going to do the best I can. And once they get into an isolation or a burn unit, then they're going to be in full contact. UK, anybody work at UK? Tell me about the burns unit. It's not existent these days, is it?
No, it's not.
Okay, why?
They shut it down.
Why?
Lack of staffing?
No. No. We can always find nurses.
Yeah, but they moved the burn unit from the old hospital over to the new part of the hospital in Pavilion A. They had some issues with that. We didn't meet our accreditation, if you will. And so like all the burn nurses, all the burn techs, all of them left and transferred to different departments.
Ask them about compensation because of infection rates. Okay. The way we live right now in healthcare, we get paid for the quality of care that we provide. Is it possible to not have an infection rate with that patient? No. Absolutely it's not. Do we need burn units? Certainly. But are they getting good compensation when people get infections after they've been there for a week? No.
So there's no
revenue generation. It is a business, what you're getting into. And that's the hardest part that I have to deal with, is the business aspect of it. Revenue is not generated when infection rates climb. Even though we understand, as healthcare providers, we have problems with the federal government doesn't. They don't get it. So compensation decreases. We can't pay the people who work in the unit, so we transition. We change that from a burn unit to something different, and we take burn patients and we ideally put them in one area, right? Because UK still gets burn patients. They don't have a burn unit, but they still get burn patients. They closed a burn unit about 2 years ago. We had a student who did their preceptorship in that unit, and it was a phenomenal experience for him. It was absolutely amazing, because every patient that comes in there is a trauma of some level, right? So you have to learn how to take care of these trauma patients who have these issues. This is a fresh graft. Can you guys see that? I know you can probably see it when you pull it up on your computers at home. Take me to that other slide, the healed graph. Something else I wanted to bring up too. Yeah. Does that look good? Does that look good? No. If that is my arm, what am I going to have? Say again. Body image disturbance, exactly. We're not going to ask you about any kind of nursing diagnosis, but I need for you to understand, as a young female or a young male or even an elderly person, if I have that to look at, even though I know it healed well and I've had a lot of pain to get me to that point, it's going to bother me, right? Okay? So someone always asks, how do you deal with that? What are some creative ways we can let our patients deal with things like that? Clothing? Somebody said tattoos? Tattoos, absolutely. There's one slide that I used to use, and it was a guy who had an amputation, and he had a dolphin tattoo put on the arm. It was really wild looking. It's kind of cool. The problem with that is, what is that skin going to do to that pigment? Is it going to stay? It's going to be really hard to get that to stay. So we're going to have to work psychologically with our patients, as well as their families in the situation. Patients who have facial burns, you guys do a great job asking about different facial burns and ways to care for that. Want to decrease bacterial exposure, certainly, but they're going to have to go to plastics. Any patients that have this right here, we're glad that they've healed, but we also have to pay attention to their body image issues, okay? So So that's where we pull into sight. I try not to ask a whole lot about sight because the Lord knows that I am not good at that. But I will throw in some stuff like that because it's important for our patients. Okay.
When you do a skin graft, I mean, they have problem with overheating because they can't sweat, correct?
I'm sorry, overheating? Yes, because they've lost their sweat. Absolutely, they do.
What is the mesh made of?
Oh, she went through it. It's autographed. It can be, you can donate from your own if you have extra tush and you want to pull it up off the tush, that's fine. Pigs, it can be amniotic membranes.
Cadaver.
So the mesh is made of that, that's not just the cover?
Right. Yes.
So
And the whole point and the reason that we have that kind of scarring, take me back to the picture. The reason we have this kind of scarring, you see the mesh, right? The skin grows in between it. So what we do is we populate this burn where we've lost this tissue, and the mesh will close itself. The skin continues to repopulate.
So is it with, like with other organ donations, like if you get it from an outside lymph node, your own?
Can you
blood
reject?
rejection?
Yes.
They
you
do
can.
like drug therapy to try to prevent.
Immunosuppressants,
Yeah.
not so much. Because
Or
what
are
else?
they immunocompromised?
Right, exactly. So do they end up having to have different